Hi there, my highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. My name is Dr. Nath Arwa. I am a clinical pharmacist by training and by profession, and I am the founder of Progressive Pharmacotherapy Consultants, a premier virtual clinical pharmacy institute for capacity building for healthcare workers. The virtual clinical pharmacy institute with a difference where patient safety, medication therapy management, and optimal clinical outcomes are very crucial and non-negotiable to us. Here, we seek to remain your premier source of crucial tips for very high impact pharmacotherapy services. So I humbly urge you all to sit back and spare me part of your very precious time to share with you some very useful tips which may prove very handy in your line of duty. So I take this opportunity to welcome you all to part 116 of our Pharmacotherapy MCQ series, Measuring in Infectious Diseases. Welcome. The first question reads, Mr. TMB, a 57-year-old black South African male patient from the slums of Soweto, is seen in a clinic. He has a chief complaint of fatigue, weight loss, cough, and a fever. He is confirmed HIV negative. A chest X-ray is done, and it's positive for a right upper lobe infiltrate. And a tuberculin skin test and the interferon gamma release assay are done, and both return positive. Is given a tentative diagnosis of pulmonary tuberculosis, PTB, and treatment is initiated using a 4-drug intensive phase regimen which comprises of isoniazid, rifampicin, pyrazinamide, and ethambutol. Three sputum samples are sent to your lab for acid-fast bacilli, AFB, smear, and culture. And all the three samples turn out to be AFB smear negative. The culture results are still pending at the moment. So my question to you is, how should the physician modify Mr. TMB's anti-tubercular therapy now with the results that are out? Should he opt to continue the 4-drug regimen therapy for 2 months, followed by 4 months of isoniazid and rifampicin, or should he continue with the 4-drug regimen intensive therapy until culture results are known, or should he change the 4-drug intensive therapy regimen to isoniazid and rifampicin only, or should he change the 4-drug intensive therapy to isoniazid, rifampicin, and pyrazinamide only? I'll give you 10 seconds to choose the correct answer. B is the correct answer. The physician should continue the 4-drug intensive therapy regimen until culture results are known. I would like to start off by saying that smear negative TB may reflect a smaller number of organisms, but intensive drug therapy, especially when it's empiric, should always consist of a 4-drug regimen. Therefore, changing 4-drug intensive therapy to 3-drug therapy is not appropriate for this patient. That makes D absolutely wrong. Now, in patients with suspected PTB, radiographic changes and negative AFB smear and culture results and a 2-month continuation phase with INH and rifampicin may be considered, but only after 2-month intensive 4-drug regimen has been administered. I'd just like to add that culture results are the most sensitive and reliable means to diagnose TB, as well as to monitor the response to TB therapy. I would like to add that no final decision about which drug to use and the duration of therapy can be made until culture results are known. So you rely on your lab. Then I would like to add that no final decision about the drugs to use and the duration of therapy can be made until culture results are known. That is very, very crucial. I'm repeating myself intentionally. Let's move to the next question, please. And the next question reads, Mr. DJF, a 66-year-old male patient, is seen in the pulmonary clinic for assessment of increases in shortness of breath, a cough, and sputum production. He has a past medical history of bronchiectasis, which has lasted for 20 good years. A chest X-ray is done, and it shows a new right apical infiltrate with possible cavitation. A CT chest is done to further confirm what the patient could be suffering from, and it confirms the presence of cavitation as well as multifocal bronchiectasis and mid-lung nodules. Mr. DJF is admitted and placed in respiratory isolation. A sputum sample is collected and sent for culture and AFB staining. Empiric treatment with isoniazid, rifampicin, pyrazinamide, and ethambutol is initiated. 48 hours later, the sputum sample is reported as AFB positive. An interferon gamma release assay is negative, and Mr. DJF is continued on his antitubercular drug regimen. 72 hours later, a mycobacterial nucleic acid amplification test is reported positive for Mycobacterium kansasi. So my question to you is, which of the following would be the most appropriate intervention, if any, in the management of Mr. DJF's infection? Would it be appropriate to switch INH, rifampicin, and pyrazinamide and ethambutol therapy to moxifloxacin 400 mg administered orally once daily alongside coamoxiclav augmentin at a dose of 875 mg orally twice daily? Or would you consider a switch from INH, rifampicin, pyrazinamide, and ethambutol to clarithromycin 500 mg orally twice a day? Or would you discontinue pyrazinamide and continue with INH, rifampicin, and ethambutol? Or would you continue the current antimicrobial regimen of isoniazid, rifampicin, pyrazinamide, and ethambutol? I'll give you 10 seconds to choose the correct answer. C is the correct answer. I would choose to discontinue pyrazinamide and continue isoniazid, rifampicin, and ethambutol. Now, I would like to start by informing you that pyrazinamide does not demonstrate any activity whatsoever against Mycobacterium kansasi. Therapy with 3 active drugs is recommended for the treatment of Mycobacterium kansasi pneumonia. And although Mycobacterium kansasi may be treated with many of the same antimicrobial agents used for tuberculosis, pyrazinamide, I'll repeat, is not appropriate. And the 3-drug therapy is recommended you can consider using azithromycin or clarithromycin instead of isoniazid if a patient, say, has issues with the peripheral neuropathy, for example. Therefore, discontinuation of pyrazinamide and continuing with isoniazid, rifampicin, and ethambutol, in my opinion, would be appropriate for this gentleman. Just like to add that clarithromycin may be used as part of a combination drug therapy for Mycobacterium cancersi pneumonia, but it should not be used as monotherapy. That makes B very wrong. Therefore, switching from isoniazid, rifampicin, pyrazinamide, and ethambutol to clarithromycin alone at a dose of 500 milligrams BD would be insufficient, inadequate. Now, just like to add that although fluoroquinolones and penicillin products co-formulated with penicillinase inhibitor combinations are occasionally recommended for the treatment of TB and other mycobacterial infections, they are not recommended for the treatment of Mycobacterium cancersi pneumonia. Therefore, switching from INH, rifampicin, pyrazinamide, and ethambutol to moxifloxacin 400 OD and Quamoxiclav 875 BD would be inappropriate for this gentleman. Let's move to the next question, please. And the next question reads, 30 days ago, nurse YKM, a 37-year-old A&E nurse, was exposed to a patient later diagnosed with PTB. Historically, this nurse's tuberculin skin test (TST) results have been non-reactive. TST was repeated 48 hours ago in YKM's case and is now reading 13 mm in induration. This female nurse remains asymptomatic. A chest X-ray is done and the results return normal. So my question to you is, which of the following would you recommend as an intervention for this nurse, Mrs. YKM, at this time? Would you send induced sputum samples for acid-fast bacilli staining, or would you perform monthly chest X-rays and treat this nurse with isoniazid, rifampicin, and pyrazinamide and ethambutol if the chest X-ray becomes abnormal? Or would you initiate isoniazid, rifampicin, pyrazinamide, and ethambutol? Or would you start chemoprophylaxis with an antitubercular regimen suitable for this patient? I'll give you 10 seconds to choose the correct answer. I would start chemoprophylaxis with an antitubercular regimen suitable for this particular A&E nurse. I would like to remind you that according to the guidelines for the CDC, individuals with documented recent exposure to a patient with active tuberculosis should be treated for latent tuberculosis infection if the TST induration is greater than 5 mm. Therefore, this A&E nurse should start chemoprophylaxis with isoniazid. I would just like to add that intensive 4-drug therapy with INH, rifampicin, pyrazinamide, and ethambutol isn't warranted in the absence of symptoms or radiographic or X-ray evidence of disease. Therefore, this A&E nurse should start prophylaxis with isoniazid alone, not with the 4 drug regimen. Now, although delaying therapy is a possibility, this nurse's relative young age and history of recent tuberculosis exposure and recent conversion of her TST all justify initiation of chemoprophylaxis, in my opinion, with INH, and I would consider that appropriate at this time. I would just like to add that induction of sputum is unlikely to yield a positive result because this nurse has no history of cough, and we are told she has a negative radiologic finding. Therefore, in my opinion, I would still insist we start chemoprophylaxis with INH, and I would consider all the other answers wrong. Let's move to the next question, please. And it reads, Mr. DMC, a 33-year-old male patient who was diagnosed with HIV infection 90 days ago, returns to the HIV Comprehensive Care Clinic for a monthly follow-up appointment. Mr. DMC has been treated with HAT, highly active antiretroviral therapy, for 90 days and is asymptomatic with good virologic response. He, however, remains profoundly lymphopenic. And his preclinical lab tests show a CD4 count of 36 per mm cubed. And his HIV physician is concerned about the possibility of Mr. DMC developing disseminated Mycobacterium avium complex, what we abbreviate as MSC, infection in the near future. So my question to you is, which of the interventions listed below would you recommend for Mr. DMC now, based on guidelines from the American Thoracic Society and the Infectious Diseases Society of America? Is it A, would you consider withholding antimycobacterial treatment until the CD4 count exceeds 50? Or would you collect induced sputum samples for acid-fast bacilli, AFB, staining and culture, and stool for MAC culture? Or would you begin clarithromycin at a dose of 500 milligrams orally twice daily, plus Ethambutol dosed at 15 milligrams per kilo orally once a day? Or would you settle for azithromycin at a dose of 1,200 milligrams orally once weekly? I'll give you 10 seconds to choose the correct answer. I would settle for initiating azithromycin at a dose of 1,200 milligrams orally once weekly. Now, the guidelines of the American Thoracic Society and the IDSA recommend MAC chemoprophylaxis with azithromycin in HIV-infected patients whose CD4 counts are below the 50 per mm cubed mark. Chemoprophylaxis should be continued until the CD4 count exceeds 100 for 3 consecutive months, note that. Therefore, initiation of azithromycin 1,200 milligrams orally once weekly would, in my opinion, be appropriate for this particular HIV infected patient whose CD4 count is 36, way below the 50 per mm cubed mark. I would just like to add that clarithromycin 500 milligrams orally twice daily plus Ethambutol 15 milligrams per kilo orally daily is indicated for the treatment of symptomatic disseminated MAC infection, not for prophylaxis. Now, this patient, in my opinion, does not exhibit any clinical signs of active MAC infection, so that regimen of clarithromycin and ethambutol would not be the appropriate one at this time. I would just like to add that there is no evidence that respiratory or GI colonization with MAC, which is usually ubiquitous in asymptomatic patients, leads to disseminated MAC disease. Therefore, collecting induced sputum samples for AFP staining and culture and even stool for MAC is not appropriate for this particular patient at this time. Let's move to the next question, please. And the next question reads, Mr. GMK, a 42-year-old male patient with early HIV infection who is treatment naive, is diagnosed with pan-sensitive pulmonary non-cavitary tuberculosis. The HIV consultant decides to defer the initiation of highly active antiretroviral therapy in Mr. GMK's case. My question to you is, how should Mr. GMK's anti-tubercular regimen differ from that used to treat similar diseases in HIV-negative patients based on the guidelines of the American Thoracic Society and the IDSA and even the CDC? Is it A, the standard 4-month true drug maintenance phase therapy should include a third drug, which should be ethambutol? Or is it true that the standard initial 2-month 4-drug intensive phase therapy should be followed by a 2-drug maintenance phase therapy of 7 months? Or is it true that the standard initial 2-month 4-drug intensive phase therapy should include a 5th drug, which should be streptomycin administered via IM injection? Or is it true that D, the standard initial 2-month 4-drug intensive phase therapy should be extended to 4 months? I'll give you 10 seconds to choose the correct answer. So B would be the correct answer. The standard initial 2-month 4-drug intensive phase therapy should be followed by a 2-drug maintenance phase therapy of 7 months. The continuation phase should last 7 months. I would just like to begin by saying that the standard 2-month 4-drug intensive phase regimen is designed to achieve rapid sterilization. It is recommended for all patients with pan-sensitive pulmonary TB, regardless of whether the disease is cavitary or non-cavitary. And the HIV status is positive or negative. Doesn't matter whether it's a positive or a negative HIV seropositivity. Extending intensive phase therapy to 4 months is not necessary for this patient. I would just like to add that addition of a 5th drug is usually unnecessary, so I would not go for streptomycin either. And I would like to add that ethambutol is typically included only in the intensive phase portion of short course chemotherapy when high inocular raises concern about drug-resistant subpopulations. Ethambutol has no established role whatsoever as a component of any maintenance phase therapy, so I would not add it to the continuation phase. That makes A wrong. And I would just like to remind you that several studies support the use of a 4-month anti-TB regimen for maintenance phase therapy, for initiation of TB therapy in highly HIV-infected patients receiving antiretroviral therapy. However, limited data is available for HIV-infected patients who are not receiving antiretroviral therapy. And the risk of relapse in such patients is a greater concern. Now, to address such a concern, guidelines from the American Thoracic Society, the IDSA, and even the CDC suggest extending 2-drug maintenance phase therapy to 7 months for HIV-infected patients, like this particular one, who are treatment naive. They are not receiving any HAT. Let's move to the next question, please. And it reads, Mr. TKL, a middle-aged HIV-negative male patient diagnosed with pan-susceptible tuberculosis, has been treated with a 4-drug regimen of isoniazid, rifampicin, ethambutol, and pyrazinamide administered daily utilizing the DOT, directly observed treatment or therapy short course. Mr. TKL's symptoms have improved markedly. Now, at his second month visit last week, he was switched to a maintenance regimen of isoniazid and rifampicin, which is to be administered once daily. A sputum sample taken at the 2-month visit was acid-fast bacilli smear negative, but cultures remain positive. So my question to you is, which of the following interventions should be used for Mr. TKL now? Should a switch be considered? Switching the maintenance phase regimen back to the 4-drug intensive phase regimen for another 2 months? Or should the team consider switching the maintenance phase regimen to pyrazinamide and ethambutol administered daily for 4 months? Or should the team continue the current maintenance phase regimen for 7 months and collect sputum samples for culture and susceptibility testing on a monthly basis? Or should this patient complete the 4-month maintenance phase regimen and then that be followed by the collection of sputum samples for culture and susceptibility testing on a monthly basis? I'll give you 10 seconds to choose the correct answer. The correct decision would be to continue the current maintenance phase regimen for 7 months and collect sputum samples for culture and susceptibility testing on a monthly basis. I'd just like to begin by saying that failure of the short course chemotherapy is defined as, in my opinion, positive cultures of MTB after 4 months of drug therapy. That is 2 months intensive and 2 months maintenance therapy. Ideally, patients become culture negative within 2 months of intensive phase therapy, but delayed sterilization with the eventual treatment success remains possible after these 2 months of therapy have elapsed. Therefore, it is too early, in my opinion, to consider this patient's response to TB treatment a failure at this stage. I'd just like to add that non-compliance is not a concern for this patient because of the use of DOT. We are told they are using the DOT approach to treat him. Then I would like to add that drug resistance should be ruled out. Now, if the pathogen is still pan-susceptible, the only intervention needed for this particular patient would be to extend the duration of maintenance phase therapy to 7 months. I would just like to remind you that there is no evidence to justify changing maintenance therapy from isoniazid and rifampicin to pyrazinamide plus ethambutol at this time. So not make that decision. Then I would like to add that switching back to the 4-drug intensive phase regimen for another 2 months would not be appropriate either. So all those many ones justify why C would be the correct answer. Let's move to the next question, please. And the next question reads, your HIV physician diagnoses Mr. FTL, a 33-year-old male patient with HIV infection with PTB. His current highly active antiretroviral therapy regimen includes 800 milligrams of darunavir taken orally once daily, 100 milligrams of ritonavir once daily, alongside 300 milligrams of tenofovir and 200 milligrams of emtricitabine co-formulated. He is taking these medications and he's been taking them for 12 months to be specific, and his viral load has been dramatically reduced. Mr. FTL's CD4 lymphocyte count has stabilized, and the HIV physician wishes to initiate intensive phase treatment for this gentleman's PTB, but is concerned about the potential drug-drug interactions involving rifampicin and the ARVs. So my question to you is, which of the regimen modifications listed below would you recommend for this clinical scenario now? Would you substitute rifabutin 150 milligrams orally once daily for rifampin, or would you start rifampin using a thrice weekly instead of a daily schedule, or would you increase the darunavir dose to 1,600 milligrams orally once a day, or would you start rifampin using half the usual dose, that is to say 300 milligrams once daily as opposed to 600 milligrams once a day? I'll give you 10 seconds to choose the correct answer. I would comfortably switch from rifampin to rifabutin 150 milligrams once a day. Now remember, rifampin is a strong inducer of cytochrome P453A, and protease inhibitors are metabolized via this isoenzyme. Now the guidelines from the American Thoracic Society and the IDSA and even the CDC recommend substituting rifabutin for rifampin in HIV-infected patients treated for TB who are receiving any protease inhibitor. Therefore, substituting rifabutin 150 milligrams orally daily for rifampin would be appropriate for this particular patient who is receiving a regimen that contains darunavir, which happens to be a protease inhibitor. I would just like to add that the impact of rifampin dosages less than the 600 milligram daily mark on the cytochrome P450 isoenzymes is poorly characterized for most drugs. In addition, using a lower than recommended rifampin dosage, that is 300, may compromise its efficacy for treating TB, especially in the intensive phase of drug therapy. So I would not consider reducing from 600 to 300, and in my opinion that makes answer D wrong. Then I would also like to add that starting Rifampin using half a dose would be inappropriate for this particular patient. Now remember, Rifampin increases the rate of metabolism of all protease inhibitors, but the magnitude of the increase varies among the protease inhibitors. Now, doubling the darunavir dosage may not completely compensate for the interaction with Rifampin, and it could lead to adverse effects from increasing or from raised serum darunavir concentrations. Now, starting Rifampin using the thrice weekly instead of the daily schedule is not appropriate for this HIV seropositive patient, so I would not go there either. So there you have it, my highly esteemed viewers and listeners. That brings us to the very end of this video. If this video benefited you in any way, I would like to humbly urge you to give it a thumbs up, to like it, and to share it widely with your peers, and to leave your comments at the very bottom. And if you haven't yet done so, I humbly urge you to subscribe to my YouTube channel. I would like to promise you all that the very, very best is yet to come, and I thank you all very much for viewing this video and for listening to me. I sincerely appreciate your partnership, your continued support, and your very kind collaboration, and I look forward to interacting with you all in part 117 of our Pharmacotherapy MCQ series. Thank you very much.